Welcome, and in this module we will be reviewing the anatomy of both the sternum and the ribs. So talking about just what the bony thorax involves, the bony thorax is going to be formed by the sternum, 12 pairs of ribs, and 12 thoracic vertebrae. Starting out with the sternum is going to be in the midline of the anterior thorax. It is a narrow, flat bone that consists of three different parts. We have the manubrium, the body, which is also called the gladiolus, and the xiphoid process. Now dividing that sternum into the three parts, just diving a little bit deeper. The manubrium is going to be the upper and broadest part of the sternum. It has a depression on its upper border called the jugular notch, which is easily palpable and is in the thorax, and it lies between the second and third thoracic vertebrae. On each side of the jugular notch, there is a surface for the sternal ends of the clavicle called the clavicular notches, which is also called the sternoclavicular joint. Moving down to the body, this is the longest part of the sternum and is joined to the manubrium at the angle called the sternal angle. The sternal angle is palpable and it lies between the fourth and fifth thoracic vertebrae. Last but not least, we have the xiphoid process. It forms the distal part of the sternum. It is cartilage in its early life, but it does ossify in adulthood. In a normal thorax, it would lay over the 10th thoracic vertebrae. Talking about some sternal rib articulations, the first 7 pairs of the ribs are going to connect anteriorly directly to the sternum through individual sections of costocartilage. As you can see on this lateral portion of the sternum, you're going to see it as 7 pairs of facets or depressions on the lateral side of the manubrium to accept the costocartilage for the rib articulation. Looking at what a typical rib would look like, rib has 2 different ends. We have the vertebral end, which is the posterior end, and then the sternal end, which is where it's going to articulate anteriorly. Looking at the posterior part, again, it's called the vertebral end, which articulates with the thoracic vertebrae. It consists of a head and a flattened neck. Lateral to the neck is an elevated tubercle that articulates with the transverse process of a vertebrae and allows for a ligament attachment. The body extends laterally from the tubercle and then angles forward and downward, termed the angle of the rib, which then leads us into the anterior or sternal end, which then articulates with the costocartilage. The anterior end also, technically the body or the shaft is on that portion, and then the lower inside margin of each rib protects an artery, a vein, and a nerve, and this is termed the costal groove, which we can't see on this picture, but when we move it here, we can see that costal groove right here for where those blood vessels and nerves are. Some rib facts. Each rib is going to consist of an arched bone, the body, and a costal cartilage, with the exception of the last 2 pairs of ribs in which the cartilage is absent. The ribs are attached posteriorly to the bodies of the thoracic vertebrae. Ribs 1, 10, 11, 12 articulate with 1 vertebral body, and then ribs 2 through 9 articulate with 2 vertebral bodies. And then the space between the ribs is referred to as an intercostal space. So, what is a true rib? Anteriorly, the cartilages of the first 7 pairs of ribs are attached directly to the sternum. So, the first 7 ribs all have its own cartilage that directly attaches to the sternum. The term false ribs is going to apply to the last 5 pairs of ribs, 8 through 12. All of the false ribs, except ribs 11 and 12, have costal cartilage that join together at the costal cartilage of rib 7. Last but not least, we have the floating ribs. the last two pairs of ribs, 11 and 12, have no anterior attachment. So this means they do not attach to the sternum or that costal cartilage coming down from rib 7 at all. It only articulates in the back at the T-spine. Reviewing kind of what we already talked about in the last module, the head of the ribs articulate with the vertebral bodies of the thoracic spine and permit only slight gliding movement. These articulations are called costovertebral joints. The articulations between the tubercles of the ribs and the transverse processes of the thoracic vertebrae are called costotransverse joints, and these permit upward and downward movements. Here's a little refresh from thoracic spine. The 12 thoracic vertebrae have whole costal facets and demifacets for the heads of the ribs to articulate with. The 1st, 10th, 11th, and 12th thoracic bodies have whole costal facets. The 1st through 9th thoracic bodies have demifacets. The 1st body has a whole costal facet above and a demifacet below for articulation with the first two ribs. The transverse processes of thoracic vertebrae have facets for the tubercles of the ribs except on the 11th and 12th processes. So we'll dive a little bit deeper into this when we actually talk about rib positioning, but just so you kind of get a small intro into how we position for ribs, I want to talk about this. So when a patient comes in for rib pain or rib exam, first thing you need to ask is, where is the patient's pain? Most of the time, again, this could depend on your protocol at your hospital, but for me, we place the area of interest closest to the IR. So in order for that, so if the patient's pain is in the right anterior upper area, the patient's chest would be placed up against the board. A lot of hospitals also use BB marker where the exact pain is, so this actually is a good locator for the radiologist to pinpoint this is actually where the pain is. So let's talk about some different positions that we would be doing. So say the patient's pain is in the left posterior area. These would be done in an AP projection. Patient's back is up against the board. And then we're going to do our two obliques. The LPO position is going to elongate the ribs, where then the RPO position will foreshorten the ribs. Talking about right anterior pain, this would be done for a PA projection. The patient's chest would be up against the board. An LAO position will elongate the ribs, and an RAO position will foreshorten the ribs. Again, your protocol at clinical could vary. Some places only do the obliques where they want to see the ribs elongate. Sometimes they don't care about seeing the ribs foreshortening, but I will show you them both at during lab time when we review ribs. Ribs should be performed erect when possible, but they can be done supine if the patient is not able to stand. I usually divide ribs into ribs above the diaphragm and ribs below the diaphragm. Difference being, if we're doing ribs above the diaphragm, we're going to be performing them on inspiration, whereas if we're doing ribs below the diaphragm, we prefer to do them on expiration. One other thing to mention when we're looking at ribs above the diaphragm, we're looking at about the light field about an inch to an inch and a half above the patient's shoulders, and just showing 17 inches as much as possible. Obviously, this is looking at both sets of ribs bilateral, so if we're doing just a unilateral study, we would be looking at just from the articulation at the thoracic spine over. And when we're doing ribs below the diaphragm, I'm putting the bottom of the light field right at the patient's crest, and we're showing whatever we can 17 inches upward this way. For example, if the patient's pain was somewhere in the lower anterior posterior area. This will make more sense during lab time, or when you can actually see it being performed. But other than that, that's all I have for today. Please make sure you review this entire video. Again, if you have any questions, we can talk about it in our next lecture. Bye.